Right, so welcome back, everyone, to the Ketamine International Journal Club. Today, we have Dr. Elizabeth Flatman, who's going to present her very recent paper on ketamine plus midazolam compared to midazolam alone for the management of refractory status epilepticus. And before that, she also kindly agreed to tell us something about herself. So, Elizabeth, over to you.
Thank you so much, Dr. Costi. So my name is Elizabeth Fletman. I really appreciate the warm welcome. I am a neurology resident at Thomas Jefferson University Hospital in Philadelphia. I'm a fourth-year neurology resident, and I will be completing my residency in June and then staying to do a neurocritical care fellowship at Jefferson. So this is a topic that I'm particularly passionate about because we see a lot of refractory status epilepticus and super-refractory status epilepticus in our neurologic ICUs. So I'm just going to start with some definitions. So the International League Against Epilepsy defines status epilepticus as a prolonged seizure that exceeds the intrinsic termination mechanisms at a certain point in time from the onset of a seizure, and they refer to this time as T1, and persists beyond a second point in time at which cortical damage occurs, and that's T2. They define refractory status epilepticus as a status that persists beyond the time of cortical damage occurring, despite treatment with first-line and second-line anti-seizure medications. So for status epilepticus, first-line anti-seizure medicines are benzodiazepines, and second lines are defined as IV fosphenytoin, valproic acid, or levetiracetam. We also use lacosamide clinically at times. And then super-refractory status epilepticus is defined as a status that persists for greater than 24 hours after the addition of a third-line agent. And the agent is typically an intravenous anesthetic. The intravenous anesthetics that are commonly used are propofol, midazolam. In recent years, ketamine's been used as adjunct therapy, and then pentobarbital or thiopental can be used. So before we go into the paper and the research, I just want to go over a little bit about the pathophysiology of status epilepticus and how seizures actually become refractory. So status and seizures are perpetuated by an imbalance between excitatory and inhibitory mechanisms in neuronal tissue. This is I thought was a really nice diagram that Dr. Espinoza and their group put in the Journal of Neurocritical Care in 2023 that really shows the synaptic changes that take place in status. So after a few minutes of prolonged seizure activity, the GABA receptors at the synaptic membrane, which you can see here, are engulfed by the Golgi apparatus and the endosomes, making it so there's a reduced number of GABAergic receptors at the synaptic cleft. At the same time, there's thought to be upregulation of NMDA receptors. So these receptors are trafficked to the cell membrane. And clinically, this shows us that patients become more resistant to benzodiazepines. So as status continues, often benzodiazepines, even high-dose intravenous, like midazolam, is not enough to terminate status. And this is one of the mechanisms that we think is occurring and why ketamine is particularly of interest given its inhibitory actions on NMDA receptors. So our study, we did a retrospective cohort study at Jefferson where we examined the efficacy of ketamine plus midazolam infusion versus midazolam infusion alone for treating refractory status epilepticus. And based on clinical experience in the pathophysiology we just discussed, we hypothesized that ketamine initiation would result in earlier seizure termination. So the methods of this study was retrospective, and we collected data from the electronic healthcare records of patients 18 years or older who received intravenous anesthetic agents for the treatment of refractory status epilepticus. And we identified two cohorts of patients. One cohort was the midazolam only cohort, and these patients were patients from about 2015 to 2017 before we started using ketamine as an adjunct therapy at Jefferson. So these patients received only midazolam as the only IV anesthetic agent for the treatment of RSE. Now, they had already received one appropriately dosed benzodiazepine followed by 2 appropriately dosed anti-seizure medicines, and then were considered refractory and started on midazolam. The second cohort is what we call the ketamine plus midazolam cohort. And these patients received midazolam infusion and had continued seizure activity with midazolam at 0.8 milligrams per kilogram per hour. And then we added ketamine. So institutionally, that corresponds with our current protocol. So what we do when someone has refractory status epilepticus is we start midazolam at 0.1 mg per kg, a loading dose when we start the midazolam at 0.1 mg per kg per hour. And then if a patient continues to seize, we double the dose to 0.2 and rebolus the 0.1 mg per kg. And then if they're continuing to seize, we go up to midazolam 0.4. And then if they continue to seize, we go up to 0.8. And we go all the way up to 2.9. Now, clinically, once a patient has reached midazolam at 0.8 mg per kg per hour and is still seizing, that's when we add ketamine. So ketamine, we do a loading dose of 1.2 milligrams per kilogram. And then we start the rate at 1.2 milligrams per kilogram per hour. And we go up by like 1.6 milligrams per kilogram per hour. Institutionally, the highest rate that we use of ketamine is 10 milligrams per kilogram per hour with a specific attending approval. Typically, we go up to 7.5 at the very highest, and we're not often hitting those heights of numbers. So the primary outcomes in our studies were time from midazolam infusion start to status epilepticus end in both cohorts, and then time from ketamine infusion start to status end in the ketamine plus midazolam cohort versus midazolam infusion start to status end in the midazolam cohort. And the rationale there was that for each of these cohorts, that was the last change in treatment. Statistical analysis, we use Cox proportional hazard and survival analysis to test the difference between midazolam and the ketamine plus midazolam cohorts in the time from midazolam infusion start to status end, and then the time from ketamine start in the ketamine plus midazolam cohort versus midazolam start in the midazolam cohort to status end. So this is a flow sheet of our participant selection. So we did a retrospective chart review. We looked at 147 charts of patients who received IV anesthetic agents for the treatment of RSE. And patients were excluded from the midazolam cohort if they received midazolam at doses less than 0.8 milligrams per kilogram per hour. And the rationale from that was that is the dose where we start ketamine now. So if a patient in the midazolam only cohort responded to just 0.2 milligrams per kilogram per hour, let's say, maybe they have a less severe status and it's not truly a fair comparison. We also excluded patients that had missing status epilepticus end times. So ultimately the midazolam cohort had 17 patients. Then we looked at patients who received ketamine plus midazolam infusions, and that was 67 patients. And we also excluded patients who received midazolam at doses of less than 0.8 mg per kg per hour, and anyone who had an atypical chronology of treatment. There were 2 participants. So for example, sometimes for focal status, we'll do ketamine prior to starting midazolam. There were a handful of instances too where patients didn't receive ketamine as the last treatment, so they were excluded. So ultimately, there were 56 patients in the ketamine plus midazolam cohort. We looked at basic demographics and clinical characteristics. You can see in this sheet that there is no significant difference between sex, race, or etiology of status epilepticus. So due to the small sample size, we had to statistically analyze the data as anoxia versus non-anoxia, but descriptively we broke down what the other etiologies of status were. And then we also looked at the Glasgow Coma Scale on admission. We looked at age at admission. That was also not different between groups. And then we looked at the Apache 2 score. And specifically, there's been data to show that Apache 2 scores greater than 21 have a higher mortality. So the idea was that looking at the Apache 2 score helped us understand if that one of the groups were sicker. And the ketamine plus midazolam group, you can see here, had a significantly higher mean Apache 2 score than the midazolam only group. The other difference between groups was the midazolam maximum dose. So in the midazolam only group, the median maximum dose was 2.1. And in the ketamine plus midazolam group, the median maximum dose was 1.6. So that was statistically significant. So we used Apache 2 score and the midazolam maximum dose as covariates in our statistical analysis.
Can you remind us what the Apache 2 score is?
Yeah, so the Apache 2 score is has to do with a number of different clinical characteristics of patients who are admitted to the hospital. So things like COPD, obstructive pulmonary disease, transplant recipients, renal disease on admission, things that we know increase mortality. And that gives us an idea when a patient's admitted, a rough idea of how truly sick they are. So this was kind of the best metric we could use to try to determine if these two groups were comparably sick.
Thank you.
So this is survival analysis. The graph on the left of your screen shows the hours from midazolam start to status end. And there is a blue line for the midazolam only group and a red line for the ketamine plus midazolam group. And then the y-axis shows percent of patients who continued to be in status at each time point. You can see here that the lines line up beautifully and that there was no significant difference between groups from when the midazolam started to when their status ends. Now, looking over here on the right-hand side of the screen, this shows the time from ketamine start to status end in the ketamine group versus midazolam start to status end in the midazolam group. So like I was saying at the beginning, these were the last interventions that each group has. So you can see that if you're looking over here, say on the x-axis and about what we think of as 25 hours here, the red group, which is the ketamine plus midazolam group, a little over 20% of patients were continuing to seize, as opposed to over 50% of patients in the midazolam only group were continuing to seize at that hour mark. So you can see that there was, a statistically significant reduction when looking at it that way. The other interesting thing to note is that in the midazolam group, in the left graph, and the ketamine plus midazolam group, when you think about that the Apache 2 score was higher in the ketamine group, meaning that those patients were objectively sicker, it's interesting to note that adding ketamine, these lines overlap, whereas you would think the sicker group maybe would have a prolonged status. And so these are just descriptive statistics of the status epilepticus resolution. So we looked at each different time point. So from status epilepticus start to status end, the initial anti-seizure medicine administration to status end, midazolam start to status end in both groups. And here you can see the median was 25 in the midazolam group and was 21.5 hours in the ketamine plus midazolam group, which is represented by those graphs. And then for the midazolam start or ketamine start, so midazolam start to status end for the midazolam group was 25 hours. And the time ketamine was started, from ketamine start to status end was 4.5 hours in the ketamine group. So then we also use logistic regression to look at the different covariates. So we looked at the Apache 2 score, like I said, and the midazolam maximum dose, because those were the two differences. You can see here that there was no significant difference from midazolam start to status end in both groups. It's not significant here. And it's still not significant when you add the Apache 2 score as a covariate and when you add the Apache 2 score and midazolam maximum dose. In the midazolam start or ketamine start to status end, you can see that there was a significant group difference. When we added the midazolam, the start and the Apache 2 score, the affected weakened to a trend. So secondary analysis that we did included a status epilepticus etiology, and this is where we used anoxia versus non-anoxia due to the small sample size, and specifically because clinically we've seen that some of the patients that have very, very refractory status are patients with anoxic brain injury. So here, this is a survival curve where you can see this blue line is midazolam only for non-anoxia etiologies. And then this is midazolam only for anoxia etiologies. And you can see that if we look at, say, hour 50, about 20% of patients have had status resolution in the non-anoxia group. And then about like 60% of patients, it's supposed to be flipped, sorry. So basically 60% of patients here who have anoxia are continuing to seize on just midazolam, whereas 20% who have other etiologies were continuing to seize. And then you can see here that in the ketamine group, looking at the ketamine and anoxia and ketamine and non-anoxia etiologies, the graphs are very close together, which makes us wonder if there's something about ketamine that's bringing the patients with anoxia into alignment with the non-anoxia etiology. So the main points that we took away from this is that there was no significant difference in midazolam start to status end between groups. The time from ketamine start to status epilepticus end versus midazolam start to status epilepticus end was significantly shorter in the ketamine plus midazolam cohort as compared to just the midazolam cohort. And then interestingly, the odds of status lasting for greater than 24 hours to becoming super refractory were significantly lower in the ketamine plus midazolam group, both in the univariate analysis and when we added Apache 2 score and midazolam maximum dose. And then, as we discussed, the mean Apache 2 score was significantly higher in the ketamine group compared to the midazolam group, which has been previously correlated with increased mortality. And so therefore, we thought it was notable that the midazolam start to status end was comparable in both groups. So from that, we concluded that the patients with higher disease severity favored ketamine plus midazolam. And our data suggests that the addition of ketamine might result in earlier seizure termination and reduce the duration of refractory status epilepticus. Randomized control trials still need to be done to determine the optimal agents for refractory status epilepticus and specifically to look at ketamine further. There's been a lot of retrospective data, but there's not been randomized control trials yet. And that's all I have. I'm happy to answer any questions.
Thank you very much indeed. That was great, Elizabeth. I really enjoyed that. Can you just go over why you think this might be the case?
Why we think that patients with higher, why specifically what might be the case that ketamine is actually working?
So if you could discuss what you think's going on in the anoxic cases versus the non-anoxic cases that makes the difference, and also just how you think the ketamine might be working in this environment. Did you want to go back to your original diagram, which I thought was helpful?
Yeah, so there have been some mouse models that have discussed like the idea that is ketamine acting on like reactive oxygen species, things like that. We don't understand mechanistically how that would be happening. I mean, outside of these are results, I do wonder if there's something neuroprotective happening with ketamine in these anoxia patients, but I can't just understand exactly what the pathophysiology is. I don't even think we understand it at an animal model yet.
And the rationale for ketamine is that it's reducing glucose.
Yeah, so the rationale for using it has to do with the pathophysiology of the receptor trafficking. Let me go back to the slide. And there have been some like wonderful animal experiments that have shown the different like receptor densities as like rats continue to seize. Also clinically, we see that ketamine works very well. So like there are patients who have like focal seizures that we don't want to have to be on something like propofol and need to be intubated. And we often can run low doses of ketamine for those patients without requiring any intubation. And it can be very helpful in like focal motor seizures, which can be really hard to control.
So what proportion of your, so did I understand correctly that very few of that you excluded the focal seizures from this?
Yeah, we excluded those because those patients received like their medications in a different order, and it wouldn't have been a fair comparison because they didn't have midazolam running at 0.8.
And how much ketamine would you be using in a focal seizures? What's the sort of dose?
I think we go up to like, we don't do it that often. We do it in our epilepsy monitoring unit. And when we do that, it's our anesthesiology colleagues that do the infusions, as opposed to in the neuro ICU with these patients. We run the infusions ourselves with the nursing. So I don't know off the top of my head the dose that the anesthesia team is using for the patients who aren't intubated, but it's significantly lower. It's certainly something I could find out, though, if that would be helpful.
Elizabeth, can I just ask you something?
Of course.
It's really just to ask, I mean, did you notice any adverse effects? I mean, I can see the positives of the ketamine versus the midazolam, or the ketamine with midazolam, but were there any adverse effects or side effects?
So, no, I mean, in these patients, we didn't see, so part of the secondary outcomes we looked at were like the whether people got tracheostomy and like pegs and actual outcome and hospital outcomes, and there was no significant difference. So it may not have had beneficial outcome effects. There weren't specific like adverse effects that we noted with the ketamine. So for example, we think about, I know that there have been papers talking about like elevated intracranial pressures from ketamine and things like that. And we have not seen that in our ICUs. Ketamine also is pretty hemodynamically beneficial, unlike propofol, where patients become like very hypotensive and often need vasopressors. Ketamine doesn't typically have that same like hemodynamic instability with it. Outside of this study, I did have a patient in the neuro ICU where we were going up to like very high doses of ketamine. We were at like 7.5 mg per kg per hour, and they did get fairly hypertensive. But it was really hard to say it's just if it was the ketamine, if it was other factors. It's pretty well tolerated.
Thank you.
Yeah, of course.
This business of the... Oh, Chloe's got a question.
Hello, Silvana here, just with Chloe, but I have a question because I was curious to know whether, because obviously you're using the ketamine here as a way to end the seizure, but what about prevention measures? Like, could this possibly, have you looked into what it would be like in that respect rather than just like termination? I was just curious to know because I'm very new to ketamine in terms of this particular use.
That's a really great question. As far as I'm aware, we haven't looked into it in like outpatient management. I will say, I know for our migraine patients, we often at Jefferson, we have like a specialized headache center that uses ketamine for the treatment of like migraine pain. And we often have, we have an infusion center. We also have intranasal ketamine that patients can get made at specialty pharmacies for like their migraine flares. So I think you make a good point of, is there some use to either, I think it would be hard to use as a true preventive, but maybe as an abortive for seizures. I think it's a really excellent point. I don't know if there's been research on that. I haven't heard of it being used that way.
Thank you so much. You're super interesting. Thanks for the talk. Thank you.
Do you think when you use it for ketamine, for migraine, is that just for hemiplegic migraine, or do you use it for non-hemiplegic migraine?
We use it for non-hemiplegic migraine. So the Jefferson Headache Unit has very, very intractable migraine patients, and some of them travel like across the country. I think there are a handful of infusion centers in the United States that do inpatient administration of medications for migraine. So we do inpatient administration of lidocaine and of ketamine for migraine.
This would be for patients who've got sort of intractable and persistent migraine that's just continuing, and it's not for sort of intermittent migraines.
Correct. This is for like really the most intractable. And we typically start with lidocaine unless there's a contraindication, and then if someone failed lidocaine, ketamine. But some patients find in our headache center, they also find that very effective.
Do we know if I mean, this diagram I think is really interesting, but do we know if this pathophysiology applies to any other disorders? For example, I'm wondering about alcohol misuse. Does that cause the same any similar sorts of disruption in where the GABA and NMDA receptors are?
I don't know, because that's not my main source of research, but I think that's a great question. And I wouldn't be surprised if there was. Given the neuroplasticity of the brain, I can't imagine there wouldn't be changes at the synaptic level. I think that's a great question. You guys have these are wonderful questions. But I do think that they're just the retrospective papers that I've read and where I hope to take this. I do think there's a lot more happening with ketamine than just the NMDA antagonism. There's everything I'm reading is that on a cellular level, it's having a lot of other effects that we don't fully understand.
There's a study, phase 2 study, that shows that, or suggests that ketamine might be useful for effectively for relapse prevention in people who are alcoholic,
Wow.
who've got severe alcohol use disorder. And there's a phase 3 trial underway at the moment testing that hypothesis. And this sort of might provide a mechanism whereby that could work.
I wonder if there are any animal studies that have looked at it.
Yeah, that would be very interesting, wouldn't it? And of course, sleep disorder is, I mean, as well as fits, obviously people with alcohol are more likely to get fits. But even once their alcoholism has resolved, when they're not drinking anymore, obviously they have terrible sleep trouble.
Yeah.
It makes you wonder if that's something to do with this GABA reset, that's in the wrong, the GABA's in the wrong place. I mean, that's just me being a psychiatrist who doesn't know.
No, I think it's all very interesting questions. And I also I don't know if we even know this. I wonder too, for the patients who are able to stop seizing.
Sorry, say again?
I wonder for the patients who stop seizing, right, when the brain renews like a homeostasis, when and how do these receptors change even after seizures?
Maybe is there anybody on the call who understands the animal work enough to be able to comment on this? I mean, Christine, is there anything you could say about that? Maybe not.
Elizabeth, I have a couple of questions, if you don't mind.
Yeah.
So do you think that basically your data may support the idea that the combination of ketamine plus midazolam instead of midazolam alone should be tried first before going to the midazolam alone in these kind of patients? And the second question I had is like, if you looked if there were any difference in terms of other mood stabilizer that the patient were actually taking. Sorry, mood stabilizer, anti-seizure medication. that's more.
Yes.
For
So
me,
I will say, to answer your first question, I think that this data definitely shows that there may be some synergistic mechanism happening between midazolam and ketamine. I don't think that in this retrospective study, the evidence is there to be able to say, yes, it was 100% just the ketamine. But it certainly shows that there is some benefit. In more recent years, we've actually been starting using ketamine earlier at Jefferson. So now we're starting ketamine with midazolam's at 0.4 mg per kg per hour. So that's like moving up how quickly we use it. And then my fellowship research that I'm planning on doing is a study of early ketamine versus late ketamine to try to look at this exact thing. Should all patients coming in with refractory status be given midazolam plus ketamine from the beginning if we know that this is mechanistically what's happening?
the idea is, sorry, so how you were saying is that the midazolam would be prompting something. So you think it has to do with the combination of the two? So it's
I think that in our retrospective data, I can't say that it's just the ketamine that made the difference, but certainly in the ketamine plus midazolam group, they seem to have beneficial outcomes. I think prospective studies, we would be able to actually answer that question better. I mean, the dream study would be to have a midazolam arm versus a ketamine arm, but you would never be able to do that, just as you know, for all the their neuropsychiatric side effects of ketamine. We always have to, at such high doses, have to have at least some benzodiazepines.
And there's no risk at all, presumably, that these were patients that were having pseudo seizures. I mean, they were all having kosher.
All of them, no, that's a great question, because those are patients who we exclude from the study, and all of these patients were on continuous EEG monitoring. And our continuous EEG monitoring is all read by board certified epileptologists. Yeah. And sorry, Dr. Costi, what was your second question?
It was it has to do with the other anti-seizure medication that they were taking.
Yes, so a lot of them, so some of them came in with like new onset refractory status epilepticus, and then some of them were patients who were already on anti-seizure medicines. We didn't exclude patients who were epileptic on anti-seizure medicines, but to be included, they each had to have an appropriate loading dose of IV benzodiazepines as the first line agent, and then get a loading dose of one of the second line agents, which we consider phosphonatoin, levetiracetam, or valproic acid. And then we also use lacosamide. I'd be interested to hear about what you're doing, everything in this psychiatry world that you're doing with ketamine, because I really have limited knowledge on the uses other than chronic pain, because we see that in neurology.
Well, I guess we use minuscule doses by comparison. That's the main difference. Tiny doses for a rather short time. So the standard starting dose is 0.5 milligrams per kilogram for 40 minutes. And sometimes people will go up to as much as 1 or perhaps 1.2 milligrams. Occasionally people go up more than that. And the S-ketamine data starts with, I suppose quite a lot of people will be taking 84 milligrams twice a week nasally to start with as a sort of induction dose, and then after 4 weeks they'd gradually the interval gets longer. I'm not aware of any. I mean, it looks as if Dr. Kubler has put in a study in the chat that looks as if it actually I can't immediately see it, but it looks as if it might be to do with TRD comorbid with epilepsy and improving the seizure control, which was sort of partly what sparked my question about refractory about pseudo seizures. But
let me just raise my hand.
Hi. What does it say? Yeah.
Hi. If I may just briefly comment, we did publish recently a case series, so with all limitations in mind, of treatment-resistant depression in both unipolar and bipolar patients with comorbid epilepsy. And it was, just the capture from the tertiary reference center, our epilepsy unit. So, real world patients, and they were treated at first standard of care for mood disorders, and with a number of failures. We do have the capacity of off-label ketamine use for the short term, and patients stay under our supervision, and it was effective. So it was alike to non-comorbid epilepsy. That was one point, but I think even more interesting was, we were very much concerned about the safety, because, you entered the unknown area, and there were no safety issues at all. But most interesting is that, for those patients, they stay under the supervision of our epilepsy unit in the long-term management, and the seizure control improved. So, they were like kind of complex to treat patients representing both epilepsy and mood disorders, and people in the productive age, and just know it was very much impactful for the general functioning. And essentially, they were far more, I would say, it's oversimplification, but they were far more manageable with regard to the general medical care. So it was really interesting, because like major point was to see safety, right? But that impact on epilepsy control was really thought-provoking.
That's very interesting. Thank you for putting that paper in the chat.
Yeah.
Elizabeth, is it your experience that people with who've got epilepsy, if they develop a mood disorder, that their epilepsy is likely to be worse controlled? I mean, obviously there's all sorts of two-way confounds there, but
I don't know if I would say that. I'm thinking of specific patients. I think for some patients, when they develop a mood disorder, it becomes particularly onerous to control their epilepsy, and that like it's very difficult for them to take their medications and do all the compliance aspects that are required to effectively manage that. I don't know if I could say that there's directly something that I've seen where people develop a mood disorder and they seem to have increased seizure frequency despite taking medications. I will say, interestingly, in our patients who undergo epilepsy surgery, we have very detailed like neuropsychiatric evaluations before, because after epilepsy surgery, patients who even don't have depression to begin with can become depressed post-operatively after brain surgery. I guess that this is a known phenomenon. So I've had patients in my clinic who unfortunately had very uncontrolled depression, have had to work up for epilepsy surgery, and the epileptologists and neurosurgeons, they're reluctant to do epilepsy surgery on someone with a poorly controlled depression, just knowing it can worsen that aspect. So that, I mean, that in
is
and of
that irrespective of where the epilepsy surgery is?
yes.
Hmm.
And so that in and of itself was something I only learned in the more recent years of my training, that I found very interesting, and I couldn't begin to explain to you exactly why that's happening.
I think this is a general concern among people in the surgery field, that they kind of having discomfort after care and compliance and the issues, so they require a lot of consultation and just no interaction and explanation. I think it's even more pronounced when we deal with the consultations for transplantation, that there is I think it's even more impactful. But regarding the epilepsy, I think this is super thrilling, because we are back to the old school German nosography, and there's kind of epileptic or epileptoid-like personality and things, and it seems to be the part of the discovery that people with epilepsy, they manifest in a different way, mood and anxiety disorders, and that interictal symptomatology, and they hardly fall into our categories of the time frame to define affective episodes. Usually these episodes are within 2 to 3 days that we would normally skip the diagnostic criteria. But on the other hand, they have reoccurring, fully manifested, full-blown mood episodes. And I think dysphoria is far more common as the equivalent of depression in people with epilepsy. And quite commonly, this is being back to the old school Swiss nosology that, Manfred Bleuler just, telling us that organic-like symptomatology, people become dysphoric for the organic origin, but for a number of people, the symptomatology resolves with the well-controlled epilepsy. So, it may be one of those niche that we have in psychiatric diagnosis, that the presentation of mood and anxiety disorders and epilepsy may be kind of distinct phenomenon, I think.
That's very interesting. I mean, I certainly mood disorders are very comorbid in our epilepsy patients. Almost all of them.
I mean, I see people having fits twice a week because I look after an ECT service, but obviously the fits are very, very short. So presumably we don't, I mean, would the animal models help us to understand that this sort of trafficking that you've outlined here, that this doesn't happen when the fits are short? or is it just that it happens to a lesser degree? Or
I from what I read, I get the impression that it's after a few minutes of seizure activity. So I don't think we know the exact time frame, but if we're considering status, 5 minutes of convulsive seizure, that's when these mechanisms start to, they begin. There begins to be some synaptic change. It certainly doesn't happen all at once. But we even see this, like, I think we see this manifestation in our ICU patients. So we get a lot of transfers from outside hospitals for higher acuity care, and you can tell if the patient's already been seizing uncontrollably for hours, it is more hard. It's much more challenging to control them. So then we're often, then I always push to be fairly aggressive with these patients if they're already intubated. Because if they've been for over an hour, 2 hours, the idea is that this pathophysiology would already be occurring. So wasting more time will make it even harder to control the seizures. It's always, of course, risk benefit though. Those are for the patients who are already intubated and already requiring that. It's a different conversation for focal status, which is why we kind of excluded those.
And Elizabeth, I think you mentioned to have also like EEG trace, right, on these patients. Do you, I mean, maybe for your next studies, or do you anticipate to be able to detect any early change, or would you anticipate to see any early change, or if you're even planning to incorporate that as well?
Yeah, so in our future studies, we'll certainly have EEG on all the patients. We're being pretty specific about what we are including in the prospective and what we aren't. There is a whole realm of electrophysiology it's called like the ictal continuum, which basically is ICU EEG terminology for a really bad EEG that doesn't truly fit all of the criteria of a seizure, like electrographically. But we know it shows this profound amount of cerebral dysfunction and synchronization. And I think in our initial prospective studies, we're going to have to kind of exclude that group of patients to try to really focus on understanding what's happening with ketamine. And then I would love to expand it to see if there are any early changes we can determine.
is it the sort of thing where you could see, I mean, ketamine causes reduced alpha power and increased gamma power, when you give it to normal volunteers. So presumably it's just too messy to see that in people who are seizing.
Yeah, we do have some very interesting artificial intelligence technology for our long-term EEGs, where it can give you like the alpha delta ratio, which has been shown to show things like early ischemia. So it would be interesting if that technology is able to pick up anything changing with ketamine in the future. But once again, yes, if someone is having convulsive status, it can be difficult to tease out the alpha delta ratio even with AI.
Sorry, just something I think you mentioned. So the dose in your case is not depending on the weight of the patients?
No, it is dependent on the weight.
Okay.
It's all in milligrams per kilogram per hour. And then the loading doses are milligram per kilogram.
Right.
Is status something that you see in people with sort of really intractable anorexia? Do you get a group of patients coming through with like that in your cohort or not?
I haven't seen that yet, but it certainly doesn't mean that it doesn't happen.
No, it's just that influences our weight per kilogram thing, because they often actually need much higher doses than the standard sort of per kilogram dose.
Oh, interesting.
If they have depression as well.
Interesting.
Yeah. Thank you very much.
No, of course. This has brought up a lot of really great questions. It's been a really wonderful learning experience for me, so I appreciate it.
I just wonder, have you got the opportunity to see the sequelae of those patients who are in ketamine arm? I mean, just what happened afterwards? And just came to my mind that it would be so much thought-provoking to check whether the healthcare resources were altered in any way. So number of like kind of index points, like number of visits, control visits, number of any kind of readjustments with regard to anti-epileptic treatment or on a sick leave, whatever. Some kind, even just soft measures, far from perfect, but some kind of just idea. Is it a kind of what some say is that transformative impact? So even a short-term management provokes kind of long-term impact with regard to more manageable course of the disease.
Yeah, so we didn't in this retrospective study. In our prospective study, we are going to try to do more long-term follow-up, even if it's just like a phone call 6 months after. I will say a lot of these patients with refractory and super refractory status end up dying in our ICUs. It's the very, very high mortality. So I don't know how many. Hopefully it's lots of patients that we can do this follow-up with, but that's one of the difficult things about this is these patients are very, very sick, and especially the anoxic patients, once they have this type of refractory status, that's one of the things we look at in neuroprognostication, and along with a lot of other things, but it is one of the things that we consider putting someone in more poor prognosis. So families often also elect to withdraw care because their loved ones are so sick.
Right. I think we are approaching the end of our session. So if nobody has any other more question, I think I say like a huge thank you to Dr. Elizabeth Flatman, who came and presented her work and also gave a glimpse of what to expect next. So we're looking forward to that. And thank you very much, all of you, to attend, and we'll see you again on the 11th of February.
Thank you so much. And you have my email if there are any questions. I appreciate everyone.
Thank you.
Thank you. Stay well.
Thank you.